To be a small part of this very excellent Frontier Symposium, and I want to thank the audience for foregoing an extra hour of sleep this morning to join us. I'm going to talk about something that's, I guess I'm going to try and introduce you to a hypothesis that's not exactly new, but it's something that's getting a lot of, or a high-profile exploration in the lay press, and that has to do with a potential association between multiple sclerosis and extracranial venous obstruction. These are my disclosures. This is the scope of what we'll cover. I realize that already some of you may have been approached by referring physicians or even patients requesting evaluations for this, surrounding this hypothesis, or perhaps asking a lot of questions. So I present this with some trepidation because I'm not able to offer you the comprehensive understanding you might have come here to try and receive, because this is truly a works in progress, and this is playing out sort of real time currently around the world right now. But I do want to emphasize that over the next few months or years, all of you are going to have the real potential to contribute to our communal understanding of the issues surrounding this possible association. So I'm going to start with ground zero and give you a background and the hypothesis behind it, talk about some initial imaging data from various modalities, talk about venous obstruction elsewhere briefly and what our experience has been with endovascular management, and then give you some insights into our current understanding, as sort of initial as it is, on what the spectrum of lesion location and etiologies are, and then a brief glimpse at preliminary clinical outcomes. So what is the background rationale that supports this association between MS and venous obstruction? Well, I've just arbitrarily chose to emphasize three particular topics here. And number one is it's been long known that MS plaques are indeed venocentric. This is undeniable from pathology. We'll talk a little about that. That blood-brain barrier breakdown is really also at the core of what our current understanding of MS is, whether you consider a vascular pathogenesis or an immune-reactive autoimmune, which is currently clearly the what is our current understanding of what causes multiple sclerosis, and then to look at extracranial venous obstruction. Well, MS plaques are indeed venocentric. Lesions extend in sort of a countercurrent to normal venous flow direction. I'll show you some pictures of that. The distribution of lesions is often periventricular, where veins occur with the highest density. And we see very typically in MS perivenous cuffs, which are similar to the appearance noted in other chronic venous diseases, such as lower extremity venous disease, Budd-Chiari in the liver, etc. Now, way back in the 1800s, when MS was first essentially understood, it actually had initially a vasculogenic pathologic origin. And in Germany, you can see one of the early investigators who drew these drawings and said, if one looks carefully at freshly altered parts of the white matter, one perceives already with the naked eye a red point or line in the middle of each individual focus, the lumen of a small vessel engorged with blood. All this leads us to search for the primary cause of the disease in an alteration of individual vessels and their ramifications. And these were indeed veins. And this is what they look like. This is back from the 1950s. And you can see demyelination surrounding a vein in a very interesting distribution here, concurrent to the flow direction. There's actually a neurosurgeon in the 30s named Tracy Putnam who was with some renown, and he actually went around looking at beagle dogs and actually injecting oily substances into the torcula and other venous locations and then examining what the effects were. And this is an article of his from 1935, and I direct you right to here, where it says the similarity between each lesions and many of those seen in cases of multiple sclerosis in man is so striking that the conclusion appears almost inevitable that venular obstruction is the essential immediate antecedent to the formation of typical sclerotic plaques. Well, so if vascular pathogenesis for MS was suggested long ago, what's really sort of reinvigorated this sort of new interest beyond sort of the current autoimmune paradigm? Well, actually MR has contributed to some of this, and especially high field MR. If we look at 7T images, this is from NYU, we can see very nicely periventricular distribution of veins, which is the typical location of where we see MS plaques. And around these individual veins, you can see lesions where the yellow arrows are that surround this very nicely, like we've seen with pathology. This is 7T from Mark Hockey, and you can see again, this is a vein and the distribution of a plaque around it. Blood-brain barrier breakdown. Well, here you have to sort of, this is sort of again where we have to sort of suspend all knowledge and sort of go with the theory. The theory is that blood-brain breakdown leads to microbleeds, and iron acts as an inflammatory agent that actually gets in there and initiates a primary lesion. This primary lesion releases excess antigen, and we start this sustained release of antigen that then provokes this immune reactive. So again, inflammation and immune reactive mechanisms are really still not displaced from this theory, but are not the primary ignition or the trigger for the multiple sclerosis lesion. The conceptual framework: the vessel wall at the blood-brain barrier responds dynamically to changes in flow and pressure, in other words, pulsatile shear stress and cyclic strain. Alterations in venous flow and pressure may elicit inflammation, thrombosis, and tissue injury. We certainly know that, like in arteries, in veins, laminar flow promotes factors that reduce inflammation. And when we have venous obstruction, we set up potential patterns for oscillatory flow, even a reversal of flow that promote inflammatory and thrombotic phenotypes. And again, I won't go into all the mechanisms. You're familiar with this at the molecular level that again promote this, but this is just an example of it. And so we end up with this conceptual framework where we see this extracranial venous obstruction involving the internal jugular veins, the azygous vein, etc., that create abnormal venous flow patterns within the brain and pressures. This increased expression of endothelial adhesion molecules that recurs as a result of this promotes chemokines, cytokines, etc. We end up with smooth muscle injury, blood-brain barrier starts to get breached, the previously immunologically privileged CNS is now exposed to cells, primary inflammation with iron is provoked, etc., etc. And this starts off this sustained sort of cyclic pathway based on this primary lesion. So what is the imaging data from ultrasound, venography, and MR in support of these? Well, the real proponent of this is a vascular surgeon from Ferrara, Italy, named Paolo Zamboni. And this really is the foundation right here, is his work with Doppler ultrasound or duplex ultrasound, looking at MS patients. He actually was scanning an MS patient and was looking at transcranial Doppler and noted that the deep internal cerebral vein had retrograde flow. And he said, I've never seen this before. This is pretty wild. And sort of with that thread sort of began to follow it. And here you can see a series of 65 patients and 235 controls. Many of these controls had other neurologic diseases but not MS. And he performed and eventually developed a number of criteria from duplex ultrasound, such as reflux reversal of flow in the internal jugular, irrespective of body position. So this is the one thing that sort of right now is on the front burners. What is the impact of body position, rotation, respiratory variation, many of these things that we can't really with MR adequately evaluate. Retrograde flow in the deep cerebral veins, which can only be assessed by transcranial Doppler, direct detection of a stenotic internal jugular vein lesion, absent flow in the jugular, even with increase in negative thoracic pressure, loss of the normal postural drainage pattern between internal jugular veins and vertebral veins. You probably don't know, but when I'm standing up here and 70% of my blood volume is down below the waist, all my drainage is through vertebral veins. My jugular veins are basically not doing much of anything. They contribute a very small amount to venous drainage, but when I go supine, that's when the jugular veins are hemodynamically preferred. So looking at these 5 criteria that he set up, he found 2 or more were abnormal in 100% of MS patients. And the mean number of abnormal parameters in non-MS patients was 0.12, okay? And the mean number in MS patients was 3.8. So this kind of got people's attention. I think most people were very skeptical, which of course is healthy, but it sort of fueled further investigation. And here from around, many of you guys have seen things like this. Here we see the jugular vein and the common carotid with reflux in the jugular vein flow going in the same directions, clearly abnormal. Here we see a right jugular vein here, common carotid artery on the left side, again, a collapsed jugular vein on the left with flow obviously refluxing. Very commonly we see abnormalities associated with the valve at the confluence with the subclavian, the brachiocephalic, with fluttering of the valves due to stuck valve leaflets. Valves are just too competent, actually reversed cusps on valves, etc. And here you can see some of that abnormal flow. So in addition to these 5 Zamboni criteria, you can oftentimes see abnormalities within the